Cek 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 cek.
Cek cek. Cek cek tes suara. Assalamualaikum warahmatullahi wabarakatuh. Cek cek. Cek cek tes suara.
Ya.
1 2. Assalamualaikum warahmatullahi wabarakatuh. Cek cek. Masuk nggak sih?
Masuk.
Aku Assalamualaikum. Oh gitu, jadi aku harus gimana? Assalamualaikum warahmatullahi wabarakatuh. Good morning everyone. Greetings to Professor Dr. Ova Emilia, Master of Medical Education, Specialist Obstetri. Masuk. Oh, udah ada partisipan yang masuk ya? PhD.
Hello, admin. Please add Studio 1 and Studio 2 as a co-host.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Greetings to Professor Dr. Ova Emilia, Master of Medical Education, Specialist Obstetric and Gynecology Consultant, PhD, the Dean of Faculty of Medicine, Universitas Gadjah Mada, Dr. Sinta Pravitasari, Specialist Obstetric and Gynecology Consultant, Education Chief of Department Obstetric and Gynecology, Universitas Gadjah Mada, Dr. Guna Segaran, PT Rajan, MBBS MRCOG, FRCOG FAMM, the Course Director of ICO and one of our speakers for today, Dr. Ahmad Sweet and Dr. Nur Zaina as ICO trainers and also our speakers for today, professors, doctors, residents, and all participants who have joined the Zoom meeting. Welcome to Expert Lecture Obstetric, Emergency Series, Complicated Caesarean Section. Ladies and gentlemen, let's open the seminar by reciting Basmalah. Bismillahirrahmanirrahim. First of all, allow me to introduce myself. My name is Natina Viniasana, as your Master of Ceremony for the next 2.5 hours. On this beautiful day, we will have some wonderful lectures that held by our Department of Obstetric and Gynecology, Universitas Gadjah Mada, in conjunction with ICO under OGSM. You might be wondering what ICO is, right? So, but don't worry, the course director of ICO will tell the introduction about what ICO and what we will learn for today later on. So before we jump on the first session, let me break down the schedule for today. So these lectures will be opened by the introduction about the ICO and also the lectures that we will learn for today, and then followed by the welcome remarks by the Dean of Faculty of Medicine of Universitas Gadjah Mada, and then we will jump on the first session that will be open with a quiz and then lectures about cesarean section, and then a demo about incision. And then we will have a break for around 10 minutes, and then we will follow by the next session that will be consist of video about normal cesarean section, and then demo about tears, and then demo about abnormalized, and then followed by quiz. And then we will have a feedbacks and also feedbacks to answer all of the questions from the participants, and then closing. Okay, so next, we will have the introduction about what ICO is and also about the lectures that we will learn for today by the course director of ICO, Dr. Guna Segaran PT Rajan. Dr. Guna Segaran PT Rajan is the course director of ICO and also a fetal maternal consultant in the Damansara Specialist Hospital. He is also qualified as OBGYN by RCOG and also fetal maternal medicine subspecialist in UK. So please welcome Dr. Guna Segaran.
Thank you very much to the Master Ceremony, Professor Ova Emilia, Dr. Sinta Pravitasari, residents of the University of Gadjah Mada, and to all the medical staff coming in today. Selamat pagi and welcome to this half-day workshop. We are very excited about this session. I first met Professor Owa and Chinta about 2 years ago when they came for one of our courses. And I'm happy that they decided to continue this collaboration and trying to share more and learn more. We have also been doing some training along the way, but this is the first time I think we are reaching out to Indonesia. We have covered about maybe 12 countries in the region, but Indonesia is the first time. So we are quite excited about it. Briefly, the OGSM stands for the Obstetric Gynae Society of Malaysia, is the national society. We have more than 1,200 members, all gynecologists. So the OGSM runs many functions. One of the main core educational component is ICO, and ICO stands for the Intensive Course in Obstetric Emergencies. So ICO has been on for more than 5 years now. We do intensive course for doctors, for midwives in Malaysia, as well as in different parts of the region. And as I mentioned, covering about 12 countries. We have an active program. Ours is more simulation based rather than normal lectures. And we're trying to do the same today to give you a bit more into how simulation training happens. Models of different fidelity. We have a website that I would encourage all of you to go into maybe later today. And it's got lots of information about ICO activities. There's lots of teaching videos as well, which you can see. And this will further amplify what we are learning today. When we first spoke to Dr. Shinta, we decided that probably we should focus on one particular topic instead of covering everything. So we chose Caesarean section. Because at least about 30% of deliveries in most parts of the world are under Caesarean. So it's an essential skill that I think all of us should be well versed with. Joining me today, I have two senior trainers who've been with me for 5 years now. They are both senior lecturers in the universities. Dr. Ahmad Shuib is a lecturer with the University of Putra. Dr. Zairina is a lecturer with University of Science, Islam Malaysia. They've been with the course for many years. They're well experienced to teach you all their skills and share their experience with you. They're all just volunteers. They've taken away time from their Saturdays and their families. So I'm very grateful to them. The course for today, we will make it into, as you heard from the moderator today, short lectures, and then followed by lots of models to show the skills. We are going to make it a bit light and easy, so enough time for you to ask questions at the end of the skills demonstration, and the trainers will be happy to show the skills for you again. It will be conducted in English, but feel free to ask in Bahasa Indonesia. We're all capable of answering that in Bahasa Indonesia as well. So with that, I'd like to thank you once again for coming to this course, and we look forward to this sharing experience. Thank you and good morning.
Thank you so much, Dr. Guna, for the explanation about ICO and also lectures that we will have for today. So next, we will listen to the opening speech by the Dean of Faculty of Medicine, Universitas Gadjah Mada. To Professor Dr. Ova Emilia, Master of Medical Education, Specialist Obstetric and Gynecology Consultant, PhD, the time is yours.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Distinguished speakers, Dr. Guna, and also the team from ICOE, all participants, seniors, welcome to the expert lectures, obstetric emergency series, with a very important topic that we are going to have today, is complicated Caesarean sections. Caesarean sections, I think, as already mentioned by Dr. Guna, is now increasing, right? But then the increase is not, sometimes it's not parallel, especially in the developing countries with the decreasing maternal morbidity and mortality. Yeah, and although it is chosen initially as a procedure to expedite the baby delivery, but means that the procedure is quite rare. But nowadays, the number is not only for saving life. There are so many indications for that. I think today's topic is very important to make us keep in track. Yeah. also we also understand that with the progress of medicine and surgical technique, cesarean sections, I think now becomes usual procedures and perhaps perceived as a simple and safe alternatives to natural birth, which I think all of us as a health provider need to redefine this procedure. So, of course, in the book of ICWE, in the handbook, I've also read it, mentioned that there is a maximum number, Dr. Guna, 19%, right? Or more than 19% is not useful. Yeah. For lowering maternal or neonatal mortality. So it is very important topics, and we are looking forward to refresh our knowledge and also our competence in this area. And we hope that this can make us more capable to anticipate and manage complicated cesarean sections. So I would like to thank you again to the team from ICWE, Dr. Gunasegaran, Dr. Nur Zairina, and also Dr. Ahmad, for sharing the knowledge and also experience. I'm very sure that all participants will enjoy the course as I enjoyed the course in ICWE 3 years ago. Yeah, thank you very much for the opportunity of this collaboration. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof. Ova, for such a wonderful speech. Ladies and gentlemen, before we start our lectures for today, allow me to inform you that you may leave questions during the lectures in the chat box in your Zoom applications that later on will be discussed in the feedback session. So before we start the first session, allow me to introduce you to two speakers for today. First, Dr. Nur Zairina. Dr. Nur Zairina is a senior medical lecturer and also obstetric and gynecology specialist, Faculty of Medicine and Health Science, University Science Islam Malaysia. She is also certified trainer for intensive course in obstetric emergencies, ICO, Asia and Oceania Federation of Obstetric and Gynecology and Obstetrical and Gynecological Society Malaysia, OGSM, since 2014. And next, Dr. Ahmad Sweep is a medical lecturer, Obstetric and Gynecology Department, Faculty of Medicine and Health Science, University Putra Malaysia. All right, without further ado, please welcome Dr. Nur Zairina to guide for the quiz.
Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Thank you so much to the Master of Ceremony. Welcome to ICO. So before we proceed, we have a quiz today just to for ice breaking, as well as to see how are you today relating to preparation for this course. So not to worry, it's just a simple quiz, not really to assess your skills, whatnot. Okay, just to know and so that we know when you complete the course day, you can measure yourself. Have you learned enough and what have you achieved your objective for today? So I'm going to share you a slide for Mentimeter. It's going to be an interactive quiz using a device. So it would be best if you're using your handphone and type in the answer. So let me share first. Lambat sikit. Alright. Sabit lagi. Okay. Okay, can you see my slide? Alright, so you can go to www.menti.com and enter this code, or easier, you can just scan this QR code. Again, you can scan this QR code to go into the menti.com our quiz, or you can just go to menti.com and enter this code. It doesn't, yeah. All right. So we have 14 of you so far. All right. We wait, at least we have about 80 participants, I think. Yeah. So at least 2/3 of you. If you don't remember what was the code, it is 18562337 through www.menti.com. All right, 17 of you. Hopefully we can get more. All right. Don't worry, we won't test you, don't worry. It's supposed to be relaxed and you should enjoy the session. So just to see how are you today. Yeah. Yeah. Okay, probably another 5 seconds. All right, we move to next question. So ready, look at your device. Yesterday was better. So there's a bit of lagging, so we wait for a while. All right. Okay, can you fill up your post now? Are you a medical officer, senior medical officers, junior specialists, consultants? All right, now we are a bit faster, yeah? Okay, get the numbers coming, yes. Okay, we have many junior specialists at the moment. Okay, almost equivalent to, yeah, just about to comment. All right. So we move to the next question. All right. Where do you work? Is it a hospital with maternity operating theatre, a district hospital, or any hospital without operating theatre, clinics or non-clinical settings? Okay, as expected, most of you do work with hospital with operating theatre. That's the reason you attend this course, right? Okay, we'll move to the next question. All right, what is your aim in attending this course today? So you may type what is your objective perhaps. There's one column there, you can type and submit to us. Don't worry, we don't know who you are. All right, so some skills, looking for knowledge, to improve knowledge, refreshing the competency. You can type in Bahasa if you want. So many looking for new knowledge, improving knowledge, enrich the new knowledge. All right. So, good to know. So we move on. Okay. Have you heard of ICO, Obstetric Emergencies course before? Yes. All right. Good figures to know. Maybe we have to work harder after this to promote our courses. And maybe after this course, we can have more future collaborations. Yeah, Dr. Guna?
Yeah.
So good to know that we have not worked hard enough. All right. So if yes, where you heard from? Whether from your friends, your consultant, recommended by your specialist, you attend scientific gathering or our websites. All right. I think Prof Oba have done a good job recommending to the younger colleague. Okay, so let's move on. All right. I presume you could able to answer this. Have you attended any courses organized by us before? As expected, majority perhaps have not. Maybe after COVID restrictions and we are a bit more better in the future, we could, you can come over, we can come over to your site. Yeah, looking forward. All right. Okay, we move to next question. All right, this is just a bit of general knowledge. Prior to 15th century, the reason of abdominal delivery to deliver the baby was due to religious reasons, saving the mother, saving the baby, or fertility reasons. Don't worry, just a general knowledge to get you warm up before we really run for the course. All right. Majority think is to save the baby. Few think saving the mother. Yeah. All right. Saving the baby first. All right. So let's see what is the correct answer. Yeah. Yes. The correct answer was actually for
Buat temenin makan.
yeah.
Enggak,
So in the
apa
15th
apa.
century, the abdominal delivery of the fetus wasn't called a cesarean section. It was called an abdominal delivery to deliver the baby for religious reason. Somehow many cultures and religions believe that the baby should be buried separately from the mother. So that's the delivery was done sort of like after the mother is died. So the baby is delivered so it can be buried separately from the mother, not really saving the mother or the baby. Okay. All right. Good to know. So we move to next question. Okay. Jacob Neuffer was said to perform the first successful abdominal delivery in the 15th century. What was his profession? So is he a surgeon, a veterinarian, a butcher, a swineherd? All right. Don't worry, there will be no penalizing marks. So many think he's a butcher, few things he's a vet, some things he's a surgeon. All right. So a vet, majority thinks a vet, yeah? A swineherd. What is a swineherd? Swineherd is people who handle pigs. Yeah, see, what is the correct answer? So the correct answer is a swineherd. It's not really a butcher. He is a swineherd. He handled pigs, no? Technically handled pigs. So he did the first successful abdominal delivery based on documentation, said that to his wife after more than 13 midwives unable to deliver his baby for almost, if I'm not mistaken, for 2 days. So it was a successful delivery, but there's no documentation how it was done or even the technique. So, and subsequently it was said the wife has successful 5 more deliveries, including a twin. So we don't not know whether this is correct or not, but this is the documented in the history. All right. So, have you ever attended or experienced difficult cesarean section before? This is your own experience, yeah? All right. So majority yes, of course, with more experience, you should attend more and difficult cesarean section. All right, majority say yes, definitely. So hopefully throughout this course, we can learn more and refresh our knowledge and skill. Do you regularly externalize the uterus while closing the uterus during cesarean section? Okay, majority says no. We wait for more figures coming. Okay. Don't worry, there is no right or wrong. We just want to know, how do you practice? Do you regularly externalize? All right. Majority did not. All right. Very small portion say yes. And yeah, a very small portion also says occasionally. All right. So we see how. Have you done any resuscitative hysterotomy before? Okay. Majority said no. Previously, it was known as perimortem Caesarean section, when we decide to deliver the baby to aid in resuscitation of the mother. Okay, majority said no. We definitely do not want to actually in real life. But if you ever had caught in the condition that you have to decide, thus you might not to proceed. All right. Thus you need to know how to do it. Okay. Okay, now you can rate your confidence in performing the skills below. So you can just, slide from 0 to 5. What is your level of confidence in performing cesarean section in second stage of labor, repairing an extended uterine test, cesarean section of mild presentation fetus, placenta previa, compressive sutures? Okay. We'll see what is the overall confidence level this morning. All right, we hope by the end of this course today, all this figure will be towards the right-hand side. Okay. Of course, most of the time you learn probably not by formal teaching, by experience. Usually you attended a case, perhaps the senior helps you to attend, and you learn throughout experience. So the more confident, perhaps more cases attended. So but we do not wish to have such cases, definitely. But practice makes perfect. So, okay, average, we are around, in the middle or less. So hopefully by the end of the course, we can move this number towards this side of the graph. Okay, we move to next question. Okay, so we are at the end of the quiz. That's all. So we shall start with our next session. Thank you so much.
Last slide. Rate your confidence.
Okay, Assalamualaikum and good morning. So everyone can see my slides?
Yes.
Okay, so I will start the lecture on complicated cesarean section. So first of all, welcome to the course, and it will be I'm grateful to be here with you all today. So as an introduction, cesarean section rates are on the rise. So as mentioned by Prof before, that we should have actually reduced the cesarean section rate to around 20%, as the rate above that will cause more maternal morbidity, and the rate below actually will sacrifice the neonatal morbidity. So we need to balance that, and according to the recommendation, the rates around 20% will be the optimum. So the risks with unplanned and complicated cesarean section are greater, so that today we hope that we can share a bit on complicated cesarean sections, so that we improve our skills and confidence to manage those cases. The recommended decision to delivery interval in Cat 1 or Category 1 cesarean section is about 30 minutes. We'll go through after this, what are the categories of cesarean section in terms of decision to delivery time. So the aim of this lecture, or the course including the demo overall, first is to anticipate and manage complicated cesarean sections, and to improve surgical safety in those cases, in management of those cases. So some definition, I mean, as we know, it's just a recap for everyone here. Cesarean section is a surgical procedure in which we deliver the fetus or fetuses through the incision in the abdomen rather than through a vaginal, or majority we say the vaginal delivery is a normal delivery. So cesarean section is through surgery, through incision in the abdomen. So that's theoretically the definition, but we know what is cesarean section. So what is the complicated one? The complicated cesarean section is the one where a difficult or complex condition among the cesarean section that include abnormal lie, placenta previa, accreta, head deeply engaged or second stage Caesar, and those who are complicated after that with extended tests, for example, primary PPH uterine atony, for example. Those are, I mean, we classify them as a complicated one. So as I mentioned before, we divide the cesarean section in terms of the decision to delivery interval time to CAT 1, CAT 2, CAT 3, and CAT 4. I think a majority obstetrician together with anesthetists, we understand the classification, and it is good for our communication. For example, if we post a case, we talk to anesthetists, okay, I have CAT 1, so they know, I mean, the staff, OT staff know, okay, what is the speed of the process, and I mean, at the end, it need to be tailored with the local protocol. So you should have a local protocol either to follow this, or you have a different language, a different classification to make things, smooth. But in majority of the centers, I think we still use this one. We communicate using CAT 1, CAT 2 to post an emergency Caesars. So some do's and don'ts. I will go through some do's and don'ts. I think the list is not limited. It's just some of the do's and don'ts. I think we have more do's and don'ts, but just the one that we listed. So for pre-operative, before the delivery, the involvement of multi-professional team is important, especially we are talking about complicated one or complex cesarean section cases. VTE, venous thromboembolism risk scoring, is important. Here in Malaysia, it is under the Ministry of Health. It is a must. There is a form to fill for every admission. We will score the VTE risk according to the patient's condition, and the management will be deal accordingly, according to the scoring or risk factor to have a VTE. We should ensure appropriate amount of blood is in reserve. So again, it depends on the local protocol. We should have the local protocol, especially for the one that we anticipate going to be a complicated or high risk cesarean section. For example, in placenta previa cases, we should have more blood in reserve compared to the normally located placenta. So it is important to make sure that before we start doing the cesarean section. The next one, you should optimize the hemoglobin level. It is very important. It has been shown in maternal morbidity meetings and audits that those pregnant mothers or parturian, we say, with anemia, with lower hemoglobin level, are associated with higher risk of morbidity or complication. So it is very important, especially in the elective case. We should optimize the hemoglobin level. For a preoperative for cesarean section, also it is important. We should include the anesthetic team to review and to assess the patient prior to the surgery, especially if you are talking about possible complicated ones. It is very important for us to reduce the risk of aspiration. So includes the position, includes the fasting or kneel by mouth, and also giving some anti-aspiration medication or anti-reflux medication. So antibiotic prophylaxis before about 30 minutes before skin incision is before the delivery of the baby, meaning that it's just before skin incision is important. And bladder should be catheterized, preferably by inserting a dwelling catheter, Foley's catheter, and anti-embolism stockings. We do practice, especially in an elective, meaning that we send for elective Caesar, especially for high-risk mothers, with the stockings worn by the mother. So during the surgery, the left lateral tilt is important to maintain hemodynamic stability and placental perfusion. And then we should ensure and ergonomics. This is very important. It's sometimes or I think very often neglected, or we oversee that, in which we as a surgeon, assistants, scrub nurse, anesthetist, everybody should have an ergonomic situation. So especially the table height, the area, and the position of the assistant. So it is very important. And double gloving, it is, universal precaution, very important. Antiseptic solution studies have shown that chlorhexidine perform better than povidone iodine, but at the end, both can be used. Adequate exposure is important. In some difficult or anticipate complicated cases, we might put the patient actually in the lithotomy position, for example, rather than a supine position. But it depends on case by case, our assessment and anticipation. Equipment and assistance, very important. So I think that's why attending one of these courses is very important. Neonatal resuscitation facilities and trained professional should be available by the site, and we will discuss more during the demo regarding the skin incision. But generally nowadays, Joel Cohen is preferred than finasteride, but we will show or we will discuss later about those incisions types. So consider prophylactic tranexamic acid, especially in the case that we anticipate bleeding. At the end, we should secure good hemostasis, especially if we involved in previous scar, for example, adhesions. We release some adhesions. At the end, we should ensure that those dissection are not bleeding. We should choose the intrant incision based on the clinical circumstances. It's not just a one technique, straightforward, a masked technique. For example, to do a transverse lower segment incision is not that alone. We have many more incision depending on the situation. So, and we should be able to choose appropriate incision. For delivery of the placenta, a control cord section is preferred rather than manual to reduce the bleeding. And use of oxytocin is important, especially after delivery of the baby. And in complicated cases, we will discuss again in the demo, we should consider sterilizing the uterus, and I will discuss that in the demo afterward. So hemostatic measures, besides suturing, we have a clamp, compression, tourniquet. You can use anything just as a basic principle of any surgery, and same goes to cesarean section. We putting a drains is not a must. It's not a standard in a normal cesarean section, but in some complicated cases, we might think about it, and we should be vigilant on the bleeding, even though it's not only in our operative site intra-abdominally, but from vaginal blood loss, especially if you are dealing about placenta previa, bleeding placental bed, angle, or near vaginal tear. So it is very important to make sure that it is not bleeding from vaginal. So while we're doing the cesarean section above. So post-operatively, in selected cases, don't hesitate to put in high dependency. We discussed with your anesthetist. In some cases, we should have ICU admission. The hemodynamic should be maintained, correct hypovolemia, and in some cases acidosis, if especially in massive PPH, for example. Again, thromboprophylaxis, we should calculate based on VTE scoring. In majority of cases of cesarean section, will need a medication, heparin, low molecular weight heparin, for example. Using the standard what you call monitoring protocols. So, for example, using obstetric warning signs is important, because we should detect hypotensive tachycardia earlier before the patient actually deteriorate into shock. Analgesia, of course, is we should individualize the use of analgesia depending on the availability, patient status, etc. And enhanced recovery pathway. I think every center should have a protocol on the enhanced recovery pathway. I think we just go quickly, and then we will discuss again later. We should avoid subluxation of rectus muscle. If we need to extend abdominal muscle, we should use diatemy, or we should to minimize the blood loss from the hidden inferior epigastric vessels below. And we don't routinely, as I mentioned before, we only externalize certain condition. And then don't hesitate to call a senior in complicated situation. Sometimes you're caught in the middle, suddenly extended tear, bleeding. You should include the senior attendants faster. I mean, we shouldn't delay. And we don't forget to assess after the, especially in complicated cases, to assess the other viscerals. For example, bowel, sigmoid colon, bladder, omentum, after our complicated cesarean section. Putting drain is not, as I mentioned before, it's not necessary. And we do not routinely close the visceral parietal peritoneum, but it is, again, is optional. Pro and cons of both of the options. We'll see the video of the disc. And we shouldn't overlook the blood pressure, the monitoring by the anesthetist team during the procedure. I think you should have a communication. Sometimes, we feel that it is everything okay, but the patient actually is hypotensive, tachycardic, hypovolemic during the CD. So the monitoring, we should engage with the anesthetist once in a while to see the monitoring how's the patient going. So I think that's all. We will put the Q&A at the end, and we also will go through that during the demo session. So with that, I thank you. And the next the lecture, Zarina will continue for the rest of the lecture.
Assalamualaikum again. So we meet again now. I'm going to continue the lecture from Dr. Shuaib. I'm going to share my screen. Can you see my screen? Okay.
Yes.
Okay. All right. Great. So complicated season section, the continuity from whatever Dr. Shub has presented earlier. So in cases such as placenta previa, as expected, in anterior placenta previa are usually a bit tricky as compared to posterior one. Thus, a placenta mapping is very essential. So a good surgeon will always do a perioperative assessment to the patient and do a placenta mapping to get a window and where could we actually do an incision on the uterus later. So when the surgery day, on the surgery day, upon entering the uterus, you could see a large vessel at the incision side, which actually at the anterior part of the uterus in anterior placenta previa. So these large vessels actually can be ligated. Do not be so daring and try to cut. That you definitely do it very fast, but you put the mother's life at risk as bleeding is already a lot and it could obscure your vision. And then as you're separating the uterovesical fold, a wide reflection would be a good one. So you know that you separate the bladder very well. Palpate the placenta edge to plan for uterine incision. At times, the vessel might not be so obvious. So as you palpate the anterior part of the uterus, you could actually feel the sponginess, the softness of the placenta, and you can feel best the edge. So it is good that you could probably avoid the edge, or if you couldn't, you probably get towards the end of the edge to minimize your bleeding. Okay. Perform hysterectomy without cutting the placenta would be the best. If the patient, the background, probably completed family and probably had 2 previous OT, previous cesarean section before and planned for tubal ligation, perhaps cutting a bit higher at the upper segment would be better and avoiding the placenta. In cephalic, perhaps an outlet forceps would be very useful in helping to deliver the baby, because at most of the time, the baby is definitely not engaged and could be moving as you try to deliver and already bleeding. And in non-cephalic presentation, delivery as breech extraction is the best. Thus, it could be best if you palpate again and stabilize the baby position prior to cutting the uterus. So in posterior placenta previa, of course, the placenta it could be delivered as a control contraction, and you can start a bit of prophylactic uterotonics. Usually, the anesthetist would give about 5 unit of uterotonics after delivery of the baby. So that will do. In cases, exteriorizing the uterus could be helpful because it will kink the uterine vessels and bleeding may be a bit less. After delivery of the placenta bag, you can pack the placenta bag with abdominal bags temporarily while you're securing your angles. This will help to reduce the bleeding that obscured your area, and at the same time, the uterus contracted. Okay. After that, please do not forget to remove the abdominal bag. Of course, prophylactic IV tranexamic acid can be given, and you should alert the anesthetist in advance that you would like to have this medication available upon delivery of the fetus. Okay, if the placenta bag is bleeding, multiple figure of 8 sutures can be done at the placenta bag. Okay, and if it doesn't work and unsuccessful, you can proceed with compression sutures such as Billinge or Hymen to help to further compress this lower part of the placenta bag. In some cases, insertion of balloon tamponade through the incision and the tip of the tube through the uterine antennal os would be helpful, as you close the uterus. If in the event it is life-threatening and the bleeding has proceeded and you are resuscitating the mother and it seems to be failing, so consider hysterectomy. Okay, Billy's compression searches. We are not going to go in depth of how to do it, but just as theoretically, because actually the video of how to do Billy's compression searches is available in ICO website and YouTube. Okay, so technically, Billy's compression searches is commonly done in cases of uterine atony or in cases that you expect some patient they will do prophylactic uterine in cases of uterine pending atony. We could probably do a prophylactic compression searches. So it is delayed absorbable searches is used, round body size 70, the needle, and usually type 1 searches. So insertion is 3 centimeter above the incision. The incision is not yet closed. Insert the first entry would be at the surgeon side, at the surgeon right side. Then you go through and through, at the just below, entering is just below the incision. Sorry, entering is just below. You might not see at this picture, just below, 3 centimeter below, and you go through and through. You come out at the 3 centimeter above of the incision side, and you bring up over it. Go to the posterior part of the uterus, and about the same level at the posterior part. Make sure there's no bowel, and you enter and through, come up to the next to it, and loop over, come back interiorly, and you enter the anterior part of the uterus through and through. The needle will come out just below the incision, and then you ask the assistant to help to compress as you adjust the suture tension, and then you tie your knot just below the incision. Okay, in some cases perhaps it's already the incision is already secured, sutured, so you may able to do these two in the same setting. All right, so detail of videos as stepwise is available in ICO YouTube. So this is just to show hemostatic searches in terms of securing the bleeding vessels in able to help to reduce the bleeding. Okay, let's say that the uterus is actually atony, and you already done your Billinge, but you're worried for further bleeding. Okay, you may proceed with uterine artery ligation, or in this slide actually to show you the internal iliac artery, internal iliac ligation, which is here. Mind you, internal iliac artery ligation require a very careful dissection of the vessels, as you need to identify first where is the ureter. It is best for you to do it with another senior person if you're not used to do this procedure. Okay, and you have a good assistant, as the identification of ureters as it comes from the posterior leaf of the broad ligament and then down the ovarian artery. So you need to identify the anterior part of the internal iliac, and then as the internal iliac is medial to the ureters and lateral to psoas muscle. So in pregnancy, at times this area, pelvic area, are edematous, and there probably some addition. So identifying your ureters could be difficult, and in some cases probably the position is a bit not at the typical position due to masses or previous addition. So identifying of the ureters is very important as one of the landmark to identify your internal iliac vessel. So ligation, it is done by the surgeon after identifying the ureters and then looking at where is the cause of the internal iliac artery, and careful measure has to be done, blunt dissection or by using bipolar or monopolar, but very, very careful because you may injure the internal iliac vein, which is very close by, and the nerves below the obturator nerves. So as you ligate, you use the delay absorbable. It can be done at both sides or one side to reduce the bleeding and up to 50%. So the videos also are available in the ICO YouTube. But perhaps if you want to know a detail more and how to do it in next course, because it will be very deep in detail to explain. Furthermore, it will be definitely difficult to master and you need to practice it hands-on. Okay, uterine artery ligation. Yeah, uterine artery ligation is far more simple as compared to internal iliac artery ligation, especially for junior specialists, in fact for the senior medical officers, because it is easily identified. So in cases that you had bleeding, perhaps following a very vascular lower segment, or the uterus is atonic and you already done your measures but you worried or even extended tear, this measure may help to reduce the bleeding. So the best is to exteriorize your uterus so that it will be a bit kink. Then you can see your own field. You need to see both sides of the uterine arteries, identify it, okay? And you may ligate it at 2 points. Yeah, very simple. But as you bite this suture, we use the delay absorbable size 1, is the same suture that we actually use to close our uterine incision. So when you do this, be mindful and palpate the uterine artery, because at times, because the vein is also running at the same course. So sometimes the tributaries, the branches are nearby. As you penetrate your needle, you probably poke the tributaries of the veins, which actually nearby if you're not careful enough. So you may actually have more bleeding and you have to redo your ligation. So uterine artery ligation are usually done on both sides. Ovarian artery ligation also another measures which is easier than internal iliac artery due to its position. So it's slightly higher as compared to the uterine artery ligation, which is a bit lower at the level of the isthmus. Yeah, you track up higher and just below the junction of the tube to the, so you can ligate here. Okay, but only one ligation. However, if you're not confident, perhaps you just focus on the uterine artery first. Do not be so daring to try all in one setting, because please remember you have the plexus of the venous plexus of the uterus as well, the ovaries down here. So it may be very tortuous due to the pregnancy. So if you're not careful enough and it's very edematous, yeah, so you may accidentally prick on the venous plexus down here and cause further bleeding and obscure your area of surgery. So please be mindful. This is again, as mentioned, internal iliac ligation artery. ligation of the internal iliac artery. So as I mentioned, identifying the internal iliac artery is very important as it crosses the pelvic rim and going down posterior inferiorly. So the first landmark which is easier to locate at the posterior part through the uterocycle sometimes is to look for your ureters. You identify your ureters, then you look for the internal iliac artery on the medial to the ureters, and need to identify your source muscle. But it's easier said than done. So practice does make perfect. Okay, it is best if you tag the ureters with a tag first, so that you do not get your ureters. Be mindful of risk of possible injuries to the subsequent veins or vessel next to it, as well as any nerve injury, or even you accidentally ligate the ureter. So it is best to practice it with another senior. Uterine angle test. So as mentioned again and again, exercising the uterus would be very helpful. So it is not compulsory to exercise uterus for all cases. Yeah. In cases of bleeding and suspected angle test, you could exercise the uterus to help to kink the uterine vessels and reduce the flow of bleeding so that you have a better field of surgery. And use an appropriate detector. Yes, you do have your Doyen detector. However, in some cases, you may having a thin diverse detectors or other type of detectors may be helpful. Use green armitage clamps to identify the apex and clamp it. Place the non-dominant hand posterior to the uterus. As you exercise the uterus, put your posterior non-dominant hand at the posterior part of the uterus to guide you, that as you stitch or you do all this procedure, you do not bind the structure at the back, which is the bowel. Okay, carefully delineate and dissect nearby structures until the apex is identified. Okay, stage suture may be helpful. So at times, the area may be a bit obscured due to bleeding, and get your assistant to help you clear the field by suction. And then if you could not identify the apex and it's coming very low down, you may need to use stage sutures, or some people call it a fishing technique. You bite first, then you secure and you try to pull. And as you dissect and try to find where is the apex. If the tear is extended inferiorly, bladder may need to be reflected further downward. And if it's extended to the broad ligament, it has to be open, and the apex should be identified prior to any suturing done. Now we proceed with abdominal presentation. So there are two most common difficult delivery for abnormal presentation, which is the transverse lie and with the dorsal superior with the back arm, or dorsal inferior. I would agree that most of you would find dorsal inferior or the back down will be the most difficult type of transverse delivery of the fetus, especially if the liqua is very much reduced in oligohydramnios or patient already in labor, leaking. So you find it very difficult to deliver through the common lower segment cesarean section. So a senior and experienced surgeon would be required. If you're able to stabilize the fetus in a longitudinal presentation prior to cutting the uterus is the best. But otherwise, if you find difficulty, you may need to start your incision with a higher up if you find it's clamped. Or if you already made an incision, you may extend to J incision. So further demonstration, we show how to deliver this abdominal presentation. So remember, of course, you need to make an incision that you think is confident for you. If you know it's already difficult and it's already impacted, maybe upper segment incision is required. And most of the time, the baby is easier to be delivered by bridge. In compound presentation, which also will be in our demonstration later, usually we already know that this LIQA would be reduced because most of the time this kind of presentation already leaked, and thus the presenting part, which is the limbs, is already out half of the way. So during the incision, we need a senior and experienced medical officer or a specialist to deliver. Plus, you need a very good senior assistant to help to cup and to push a bit part of the limbs as you were delivering. So most of the time, if you can feel that the head is nearby, you can do your usual lower segment cesarean section and deliver the head. And as you deliver the head, the baby will automatically come out with the hand. Yeah. And if it's already far beyond, like hand prolapsed here, maybe an assistant need to help, not to push so hard, but the assistant could help to guide the hand up. We will demonstrate further for this. However, if in hand prolapse or compound presentation, which is already compact, in labor and LIQA was definitely diminished, you might need to consider the incision. If it's a lower segment, you may need to consider extended incision, the J incision or T incision to help to deliver via bridge, or might as well an upper segment, but it will be a bit tricky to repair. In a second stage a cesarean section, which is also will be in our demo shortly, there are many methods to deliver. Definitely, there will be some difficulty. Thus, you need an experienced surgeon, an experienced assistant, because there are commonly three methods, but the most common is two methods. Is either you push or you pull the baby up. So most of the time, the assistant need to push the presenting part in the operating theatre using a cup hand, not using a VE, but using a cup, so that the pressure of the baby head pushed in would be equally distributed. So, and it's done prior to cutting the uterus. So as we cut the uterus, we use the non-dominant hand, if the surgeon on the right side and right-handed. So we use our non-dominant hand to scoop the baby's head until our hand meets the person who pushing the head from below, and you lift up the baby and deliver the baby. That is push technique. Pull technique is at times you just need to deliver the baby by bridge extraction. Now, further details will be explained in our demo. Just now was push technique. This is our pull technique, as mentioned. Because the head is very low down and impacted, sometimes the vacuum created at this area will be very difficult, and you consider the use of uterotonics at times, or at times you may need to consider delivery by pull technique easier. And remember, if you in this condition, because the uterus is very thin and extended tear is anticipated. Okay, resuscitative hysterotomy. Resuscitative hysterotomy is usually done in a mother in the condition where you need to help to reduce the compression on the endocarpal of the mother to assist the mother resuscitation. Because of the graviuterus compressed on the endocarpal, the weight of the baby and the size of the uterus, as well as the lung volume capacity due to the graviuterus may be limited during resuscitation of the mother. Thus, if the maternal collapse and you need to decide quick to deliver, the incision made usually is a midline, vertical, sub-umbilicus. Most of the time, the equipment required is not so much as compared to an operation theatre setting. It actually can be done anywhere in the hospital, because you don't need to transport the patient in an operation theatre. In fact, in the ICU bed, in emergency department, wherever the resuscitation is done, and you think that it could aid the maternal ventilation and cardiorespiratory ventilation and also resuscitation. Okay, so when it is done, of course, we will also alert our pediatric colleague to the baby, but it was not meant to save the baby, it was to save the mother. The intention is to save the mother. Okay, during this time, the resuscitation such as cardio, the chest compression, chest compression, the ventilation as ongoing, and as you have your equipment such as your disinfectant, scalpel blade, your forceps, your needle holder, needle and scissors, Mayo scissors. So just a simple disinfection this area, and then you make a midline vertical incision, then open in layer, and most of the time is bloodless due to mother condition. The blood pressure is very low, so and as you enter the uterus, you take the baby out, pass the baby to the pediatric colleague for further resuscitation if the baby could make it, but the main point is the mother. And as you close the uterus, you close in single layer, and most of the time bleeding is very much less, not so much, yet you could close the uterine in single layer, and the skin could also close in single interrupted stitches, so because we worry if the mother BP pick up, bleeding may occur. All right, so mainly to save the mother. Okay, risk and management. Okay, in resuscitative hysterectomy and in any difficult cesarean section, of course, during the consent taken, you should counsel the couple regarding the indication, the incision type, and the details of what perhaps could happen and measures will be taken. So document everything in the consent, and of course, counsel regarding immediate and long-term complication, especially there is ligation, extra hemostatic ligation or compression surgeries done. Most of the time are quite fine, but you do not know who will develop long-term complication. All right, Robson classification for auditing on comparison of data is required. You should, classify the category of section and document everything for auditing to improve further. Ensure correct surgical count and instruments and swab, especially in as massive bleeding, a lot of abdominal pack are used, the instruments involved, and thus you need to make sure no other further complication related to instruments and swabs. Document post-operative plan with appropriate multi-professional involvement, and audits are very important, and adherence to available guidelines to ensure that we are on the safe track. Regular advanced key training such as this on complicated cesarean section is required, so that because sometimes we do not learn direct from a course, because usually based on experience attended with our senior colleague, and you could not really learn properly. So that's attending this kind of course would be good refresher to us. All right, so we can proceed with question and answer towards the end. You may type in the chat. Then further details will be in our demo shortly. All right, thank you.
Right. You've been hearing the lectures. Now, as you know, the topic is so huge, we can't possibly cover in such detail. So we made it in a point form over about the last 20 minutes. You can go back and look at the ebook to see most of the points about the Caesarean section. Now this part, welcome for the demo. And we're going to have 3 demos, starting with the first demo. As I can see from the Mentimeter, at least 20% of your participants have less than 5 years experience. So some of the things teaching you will look quite basic, but we're trying to cover, the basic and the advanced level as well. So for the first part, we'll be using the SIMAM as a model. One of the most important things in a Caesarean section that you must do is always about planning. So way before you attempt the incision, you've already planned in your mind how you're going to do it, why you're going to do it, who's going to do it, and who else is going to be around you, so that you're now optimize the outcomes. And one of the most important things of this planning is your access. When you want to go into the C-section, you want adequate access, but not too large, for you to reach into the baby, deliver, and attend to complications. And the access can be both in the abdomen as well as in the uterus. So we're now going to take you through the different modes of access for the abdomen and for the uterus. And for that, I invite Dr. Zarina.
Thank you, Dr. Guna. So we are going to demonstrate how to make the incision for Caesarean section. At this station, I presume this patient already consented and already under anesthesia, and she is already cleaned and draped. So we focus now to our incision. This patient and the indication is already clear. So you make sure your assistant already have your instruments. Definitely your scrub nurse already mentioned that you are ready. As you proceed, make sure this is a correct patient. So as you proceed with Caesarean section, presume this is your patient. You already palpate this patient. Yeah. So the uterus, this is the symphysis pubis. So a normal phalansteal incision is usually about 2 centimeter above the symphysis pubis and around your 2 finger breadth if you want to measure. And you can make sure that your incision is on the correct and equal length. Yeah, usually around 12 to 15 centimeter inside. So you already know it's here. So presume I'm holding my apple, yeah, and you hold it like holding a pen. To proceed with in phalansteal, usually it's just a straight line, yeah. Okay, so as you enter, then you can proceed with incision of the subcutaneous tissue until you find your rectus. Further demo of rectus incision will be shown in the video later. So there's another incision which is quite commonly used, is Johel Cohen, usually about 2 to 3 centimeter from the symphysis pubis, and it's most of the time it's a bit curved upward. So presume that the same spot I'm doing. So
just cutting through and a bit curved up. All right. And later you do blunt dissection. So as you enter and you go through and through until you find your uterus. So there also other type of incision which is quite commonly done, which is the midline vertical. Yeah, midline vertical can be from the umbilicus, just below the umbilicus. Yeah, in cases which are probably anticipated difficulties, such as in cases of pelvic masses, pregnancy with pelvic masses, fetus with conditions such as impacted fetus in second stage, or even severe fetal bradycardia, or even in a severe addition in patient who had previous multiple surgeries and already noted in the previous surgeries it was a difficult one with addition, especially at the lower part, and the bladder is high, and or she already had a previous vertical incision. So you may proceed with a midline vertical incision, and usually you have to make sure that as you enter, as you enter through and through, you separate the abdominal wall in layers. Be mindful as you enter the uterus, because if she had previous surgery before and you enter an upper midline vertical incision, risk of injuring the bowel is slightly higher. Okay. In some cases, perhaps you already done a lower segment caesarean, either Johor Cohen or Peninstil, but you find there is difficulty due to difficult access, addition. So you may proceed with malar incision. Malar incision is usually used for a gynecology incision, or 4 centimeter above the 60 base. However, this original fantasy or Johor Caesarean, which is suprapubic, can be extended as a malar, whereby you just need to extend it towards the end of anterior superior iliac spine, 3 centimeter from it. So you extend. Yeah. You extend. Okay. And then as you go through and through, the rectus muscle is cut. It's cut. Yeah. And you need to dissect until you find the edge of the rectus muscle and separate so that you had a very clear margin. And because next to it is the inferior epigastric vessel, which is very crucial for you to identify and properly ligate so that you will not have a massive bleeding. Okay, so you do it on the both side, and then you proceed entering the peritoneum. Okay, now we proceed with the, presume that I already entered my subcutaneous layers, then my rectus, again for a normal cesarean section, yeah. Then my rectus, I go through the peritoneal cavity and I found my uterus. So this balloon is my uterus. So you have your assistant putting the doyen, yeah. Thank you. The doyen. So perhaps if sometimes a bigger doyen would be helpful, to deflect and protect the bladder. And then the best, as a surgeon, you need to put your hand inside and feel where is your round ligament is. Because most of the time, the uterus is dextro-rotated. So if you do not palpate, do not know where is the round ligament properly, you might not do the incision slightly a bit lateral, and that may extended tear could happen. So as you palpate and you know where is your uterines and the uterus is slightly dextro-rotated, you know where to make an incision. And usually you need to separate your UV fold first. Yeah, you separate and you further deflect so that you protect the bladder. In previous case, you might not able to separate it properly. So incision might be a bit higher because the bladder is there. So as you use your scalpel blade, and focus a bit here, all right, hope you can see. Okay, we remove this doyen for teaching purpose, otherwise you're unable to see it nicely. So you make your incision at the lower segment, okay, you cannot see, there. The marker is there. Yeah. Usually you make one single. Be careful and mindful that you worry. You might, if it's very thin, you might hit the baby straight away, and then further injury to the baby. So very gentle. You swipe away. Yeah. And you feel the depth. If you feel that it's less than 5 mm thickness, you can probably proceed with using the curved artery. Curved artery. Yeah, we don't have curved artery here today, but presume my right angle is a curved artery. So I'm going to go in, yeah, we demo and follow the curved artery trace. Then we will cut. You can cut to guide where is the tear that you want it to be, and some would probably tear because the uterine muscle is actually following this curve. So if you tear, probably less bleeding. But in cases that is very thin out lower segment, you don't want to tear because you cause further tear extended to the lateral side. So this is our lower segment incision section. In cases that perhaps there is difficulty of the delivering, anticipated as mentioned is placenta previa or spectrum of Equitas. Yeah, okay, assistant holding the uterus. So you may need to go for a all right, a bit, yeah, a bit. Sorry, I changed the pen first. Yeah. Okay, so this is just now our incision. So the non-projectile part maybe in DLIS, DLIS incision, you make like this, not together, This presume you're going to enter on the higher up. If there is a difficulty or addition or something that you try to avoid down here to deliver baby, so as you do, and you enter the uterus and deliver the baby. Next is if in cases that we change the, yes, all right. So in cases that perhaps a placenta previa completed family after this delivery or morbidly adherent in placenta spectrum of placenta Akita, you might want to enter a classical incision at the contractile part, upper part of the uterus. So the best is you to avoid touching the placenta, very vascular area down here, or in cases there is pelvic masses, so you want to avoid, so you might need to go higher up incision. So incision are made on the upper segment and you go by layers. The problem, the upper segment is usually a bit thicker and more bloody. Okay, so you expect more bleeding, so you have to alert your surgeon. So get the baby delivered most time probably by bridge, and you proceed with closing. All right. Okay, in cases where, okay, we get a new area. All right, in cases where probably in impacted fetus, especially in transverse presentation or prolapse, when you do a cesarean section, as usual, you already done it, but you have difficulty in delivering, especially in cases which is transverse like dorsal inferior, the back is down and the liqua is very minimal, very difficult for you. You might need to extend your incision, and you go, this is J incision, you go laterally up to the upper segment. Don't worry, as long as you can take the baby out. After this, we repair. Okay, so we repair after this. So we go up, this is J incision. If you find it's difficult access to deliver the baby, you do double J, to the upper segment, and get this baby delivered. There are also conditions where an inverted T is done. Similar indication, difficulty in delivering the baby to get the access. You might go in the middle like this. However, it's a bit challenging to repair as the healing in this part would be better. So usually we will do J incision one side, and if we still inadequate access, then the other side. So double J. But do be mindful because expected further bleeding will occur. So alert your anesthetist and you perhaps need to get a blood backup. All right. So next, we presume that we are going to deliver the baby and cutting the uterine layers. So this is just a simple basic refresher. Okay. Okay. So I'm going to demonstrate to you how to cut the uterine layer using scalpel, a real one. So as you see, this is my uterus. Okay. Okay, this is the uterus. The color is not pinkish as our mannequin had a skin colored, but this is my uterus. Okay, so you already palpate the baby's head is here. I'm going to show you how to do the incision to make sure that you do not injure the baby. Yeah, so as usual, you hold your scalpel blade. Yeah. So you know already bladder is the UV fold is already separated and already deflect with doyen. So for teaching purposes today, I'm going to remove this doyen. Otherwise, you might not see clearly. So I'm going to make some incision here. Yeah. So this uterus is a bit thick. So, and this patient is a bit bloodless. Yeah. So as the incision is already made, this is a right angle, so we don't have a curved artery, but presume that this is the curved artery. So I need to go. Yeah, this uterus is very thick. Yeah, I think this. Yeah, I need to cut furthermore. This uterus probably is a premature baby. So in premature cases, uterus is a bit thick. Yeah, probably doing hysterectomy. So I need to cut a bit more the layers. Yeah, I'm almost there. So, all right. Okay, can I get Mario scissors? So this baby, this uterus is a bit thick here. So don't worry, just use the, need to open the layers of the uterus. Okay, gently you can feel you're just near the baby. You can feel the baby head. Use your finger for blind dissection because it's the best that if you can deliver the baby intact. So usually you can tear it. But this patient is a bit thick, so I need to cut them. Now I'm happy. It's a bit easy. Okay. Okay. So presume I'm cutting. So you can see the balloon. So this is the membrane of the baby. So my baby is intact. Yeah? So you can make the incision wider, or if in cases that is a bit, you worry that it will tear further, you cut nicely so that it won't tear laterally. So see your baby, you can actually scoop the baby out. Yeah. Okay. So of course you can cut the membrane as well. If it's premature, you can deliver inside. All right. Yeah. All right. Okay. Any questions? You can type in the chat box. Perhaps we can update at the end of the course. There's a question and answer session so that we compile everything. If you need us to re-demo, we can show towards the end. Yeah? All right. Thank you.
Okay, thank you, Dr. Nur Zairina and also Dr. Ahmad for such a wonderful and clear explanation about the cesarean section in uncomplicated and also in complicated settings, and also the demo about the incisions. Maybe may I have some applause for the speakers for today? All right. All right, for the participants, I feel like we have learned a lot in the first session, but don't leave the Zoom meeting because we will have a session 2. There will be a video about normal cesarean section and demo about tears, and then demo about abnormalized, and also we will answer all of the questions in the chat box. And also, let me inform you that don't be shy to leave questions in the chat box. Just leave all of the questions in the chat box, and we will discuss it in the feedback session. Okay, so before we jump on the session 2, we will have a break for around 5 minutes, so you can enjoy and relax or have some coffee before we go to the session 2. So see you in 5 minutes. Iya. Ladies and gentlemen, welcome back to the expert lecture of Obstetric Emergency Series, Complicated Caesarean Sections. All right, so for the next session, it will be video of normal cesarean section and then followed by demo about tears and then demo about abnormalized and then there will be a quiz and then will be closed by feedback that we will answer all of the questions in the chat box. So let me inform you again that don't be shy to leave a questions in the chat box because later on we will try to answer all of the questions from the chat box in the feedback session. So all right, without further ado, let me invite Dr. Nur Zairina to guide the video session. So to Dr. Nur Zairina, the time is yours.
This video will show how to perform a caesarean section safely. Firstly, the abdomen is thoroughly cleaned with an appropriate antiseptic and the area is draped. You will learn how to perform a fan steel incision. This incision is the best to make in almost every circumstance as it heals well with minimal discomfort. With experience, you will be able to form this incision quickly enough for all obstetric emergencies. The pubic symphysis is palpated. The incision is made approximately 2 finger breadths above the top of the symphysis or just below the pubic hairline. The knife should be held at right angles to the skin and the incision should be cut in a straight line parallel to the top of the pubic symphysis. The incision will generally be around 12 centimeters long. Care must be taken in cutting through the adipose tissue layer under the skin, as there are frequently large blood vessels running through this layer, particularly towards the lateral edges of the incision. It is best to identify these vessels and either cauterize them or tie them off before they are incised if possible, as otherwise the ends tend to retract into the tissues and may be difficult to locate. Once the adipose tissue is open, the rectus sheath is exposed. This is also opened horizontally in the same way as the skin. Care must be taken to avoid cutting too deeply and incising the rectus muscle underneath the sheath. The incision is made centrally with a knife and may be extended bilaterally by slipping the scissors underneath the sheath through the hole already made in order to separate the sheath from the rectus muscles, and then the sheath is cut. The curve of the scissors should point in the upwards direction. Alternatively, the incision in the rectus sheath may be enlarged with a knife, taking care not to cut too deeply and avoid the muscles. The sheath is then elevated and separated from the rectus muscles, allowing plenty of room. The sheath is also dissected off from the muscles in a downwards direction. Do not stretch open the rectus muscles by placing fingers directly underneath the muscles. There are perforating blood vessels coming through from the peritoneum which may be ripped if you do this. These vessels may then retract and become very difficult to trace and cauterize. If undetected, these torn vessels may lead to the development of a rectus hematoma later. It is important to be able to open the peritoneum high up, particularly when doing repeat sections, as the bladder may have been pulled quite high up by the previous scarring. The fibrous tissue joining the pyramidalis muscles may be divided, taking care to cut superficially so as to avoid damage to the underlying bladder. The opening may be extended by means of the 8-finger stretch. The surgeon and assistant put 2 fingers from each hand into the incision and gently pull it open. The uterus lies immediately under the opening. The visceral peritoneum is opened. A small horizontal incision is made into the myometrium centrally. The knife is wiped gently over the muscles, gradually deepening the incision until the fetal membranes are visible. The uterine incision is then extended bilaterally. I think it is preferable to use scissors for this purpose, with the curve of the scissors pointing in a headwards direction. In this way, the large vessels situated laterally are more likely to be avoided, and if the edges of the incision extend during the delivery of the baby, the angles are less likely to extend downwards towards the ureters. However, many surgeons do extend the uterine incision using their fingers, and it is perfectly permissible to do it in this manner. If the scissors are used, then the surgeon's fingers are inserted under the blade to protect the fetus from trauma. Next, the baby is delivered. The surgeon places their hand under the fetal head and guides it up through the incision, whilst the assistant applies steady fundal pressure. If the head is high and is not advancing easily, then Wrigley's forceps may be used to assist. The application of these forceps will be demonstrated later. In cases where the fetal head is impacted deep within the pelvis, it may help to have an assistant push the head back upwards by applying pressure from within the vagina. It is best to start this before the uterus is opened, as sudden decompression may result in an extension of the uterine incision angles. After the delivery, provided the baby is in good condition, it may safely be left for a few seconds between the maternal legs, whilst the angles of the uterine incision are dealt with. There are often large blood vessels in these angles, and considerable blood loss may be prevented by the early application of green Armitage clamps to these angles. Once the angles have been clamped, the baby may be shown to the parents and handed to the midwife. Obviously, in cases of prematurity or fetal distress, there should be no delay in passing the baby straight to the midwife or paediatrician for resuscitation and warming. The placenta should separate spontaneously after the anaesthetist administers a syntocinon bolus. Once the placenta has been delivered, it may be necessary briefly to remove the green Armitage clamps from the angles in order to remove any remnants of the membranes. The upper part of the uterine cavity should be explored digitally to ensure that none of the placenta or sac remains. There should never be any retained product left after a caesarean delivery. Both uterine angles should be stitched separately before the uterine incision is closed. It is important to inspect the angles carefully both inside and out. In certain cases, some of the muscle fibres can have torn further laterally on the inside of the incision, and it is important to get the angle suture behind any such split to avoid internal bleeding. The angle suture should not be too wide, as shown. This is an important hemostatic suture, and therefore the pedicle should not be unduly bulky. I prefer to take a couple of further sutures and then retie the angle to make sure it is totally secure. It is imperative to ensure the angles are tied tightly to avoid any bleeding later on. The uterus may be closed using a single or double layer of sutures. I prefer to use a double layer. The bottom edge of the incision will appear to be longer than the top edge, because the top edge of the incision is attached to the bulk of the uterine musculature and will therefore retract as the uterus contracts and appear shorter. In closing the incision, this must be allowed for by leaving slightly longer gaps between the sutures on the bottom as compared to the top of the incision. When tying knots, always remember to bury the tip of the needle within the teeth of the needle holder in order to avoid needle stick injuries. The first layer of sutures is inverted and buried by the second layer. When starting the second layer, do not go beyond the angles already sutured, as there are large blood vessels laterally, and if they are not bleeding, you don't want to cause them to start. Once the uterine incision is closed, it must be inspected carefully for any residual bleeding points which must be secured. It is important to inspect the incision without placing it under any tension, as tension will often result in compression on the feeder vessels and make the incision appear dry. It is very rarely necessary to exteriorise the uterus, and almost all repairs may be completed with the uterus in situ within the abdominal cavity. It is not necessary to suture the visceral peritoneum closed, and indeed doing so may result in the bladder being drawn upwards in such a way as to place it at greater risk of damage during any future surgery. The ovaries should be inspected to rule out the presence of ovarian cysts. If you do enough caesarean sections, every once in a while you will probably find an ovarian cyst which must be dealt with, as failure to do so could result in torsion of that ovary during the period of uterine involution. To visualize the ovaries, place the hand over the uterine fundus and then sweep gently down either side. The tube and ovary will be palpated and can be brought gently forward for inspection. It may be difficult in some cases to locate the ovary, but in the absence of previous surgery or pelvic adhesions, the ovary will always be there. Those that are hard to locate are more likely to contain cysts and have been dragged up the paracolic areas or down into the pouch of Douglas, so do not give up until you have found and inspected them. There is some debate as to whether it is necessary to close the parietal peritoneum. In the short term, it probably makes little difference. However, in the longer term, because of the divarification of the rectus muscles, there remains the risk of either the omentum or even loops of bowel becoming stuck to the back of the rectus sheath, rendering further surgery more difficult and dangerous. I therefore prefer to close the parietal peritoneum. Care must be taken not to include any underlying bowel or omentum in the suture, and also to avoid the underlying bladder at the bottom end. The fibrous tissues in the midline towards the bottom of the muscle layer may also be repaired. It is important to check for any bleeding from perforating vessels between the rectus sheath and the muscles, and secure these vessels appropriately before closing the rectus sheath. These vessels may be in spasm, but may later relax and contribute to a hematoma if not secured. The rectus sheath is then closed with a continuous stitch. This layer is not hemostatic and should not be pulled too tight in order to avoid unnecessary post-operative pain. It is merely necessary to oppose the edges of the sheath in order that they may heal together again. A stitch to the scarpus fascia in the adipose layer may be used, although this is not strictly necessary. The skin may be closed with a subcuticular suture. If the
Okay, so welcome back. You have watched the videos on the normal step of cesarean section. So for the next demo, I will demonstrate to you about the management of different tests in complicated cases of cesarean section. So the scenario is your junior medical officer who just started doing cesarean section, performing cesarean section for a case of, let's say, a macrosomic baby. Some difficulty in scooping the head, delivering the rest of the shoulder and body. Possible some junior assistant also doing some incorrect technique of fundal prayer, for example, and ended up after the delivery, he cannot see anything, blood everywhere, and he just said that I cannot visualize or I cannot identify the tear after the delivery. So that's quite a common scenario. Another scenario is a senior already performing a cesarean section for an anticipated difficult cesarean section, for example, deeply engaged head, but the extension or extended tear might happen. So that's why we must always, brush up our skills, teach our juniors on how to do that. And this is the importance of simulation, because you cannot teach, you cannot just teach an extended tear in normal cesarean section, because everybody panic, calling for seniors, and you don't know when you will get such cases. So today I will, that's the scenario, all right? So if you see, I will show you multiple situation or multiple condition. So in this model, I will show you the lateral extended tear to the lateral angle, and including injury to the big vessels, is uterine or the big branch of uterine arteries. And another one is the extended tear downwards towards the bladder. You may find actually multiple other types of extended tear. You can find at the middle, downwards towards the bladder, and extension to the upper segment, especially if you do J incision. So there are multiple types, but the most common and that I will show you, first, you will find the first scenario or situation is the extended tear to the lateral. Before that, if you encounter that situation, for example, you receive a call for a junior, like in first scenario that I gave you. So first of all, you need to tell them, or if it not being done, they need to inform the anesthetist. This is a possible, hemorrhage, and you need to ask them, okay, if you cannot identify anything, we just can pack the area that you see that she or he think that is a possible bleeding, if he cannot handle and waiting for you to come. So tell the anesthetist, prepare for the blood, and tell the anesthetist that, okay, it might be the a hemorrhage or a severe PPH, a major PPH. So all right, so I will show you for extended tear. Usually we emphasize you to exteriorize or to bring the uterus out from the skin incision, from the abdomen, because I will show you why we need to do that. So how to do that? Okay, so you put either non-dominant, or I like to use my own dominant hand actually, okay, to take the fundus. But we need to inform the anesthetist, because some patient, especially under spinal anesthesia, might have vasovagal attack when you do this. So you bring the uterus out from the fundus, okay, and all right, so now you the uterus is already out. It is important because you can see anatomy more clearly. You can see the angle, right, and you can avoid injuries to other organs. Okay, so few principles of let's say in this situation, this is lateral tear, some bleeding over there, and actually is the bleeding is here is from uterine arteries. So all right, so what you need to do after the exteriorize, you need to clamp the bleeding. Let's say for this situation, before you identify the angle, you already see the bleeding of the from the vessel. So you can clamp the vessels first. You can use green army touch, or alternatively, sometimes you can use another clamp. For example, if you identify actually a vessels jutting out like this, you can just put the right angle. Okay, so before you are dealing with the repair, you need to make sure that the other anatomy or the other organs is secured. For example, a lateral tear, you are talking about sigmoid, if any adhesion, and ureter is just close by. So you need to identify. In this case, I can see the apex, okay, just right here, but it had torn the uterine artery. So I will repair the uterine artery, or not repair. I will suture the uterine artery first. So the technique, first you have identified where's the uterine artery, the cause of the uterine artery. Usually, if you turn the uterine artery, majority of the time, actually, you have injured the broad ligament. So you need to open the broad ligament, anterior, especially the anterior leaf, so that you can see the vessels. Okay. So I guard the back of the uterus. That's why I need to exteriorize, because I want to avoid the ureter, the yellow tube over here. Okay. So to repair, I just a suture from either from medial to lateral, it doesn't matter. Your hand back, your fingers on the back of the uterus to guide you, so that it doesn't perforate below. I mean beyond the posterior part of the uterus, so that it may injure the rectum, sigmoid colon, for example, and the ureter. Okay. And then you tie. Okay. You can remove the clamp just to check that whether you have actually secured the tear, the vessels. Okay. Okay, that's for the vessels. Most of the time, if you you will have also the bleeding from the veins from above. If the tear had the artery and vessels had been, and veins had been injured, so you need to also secure or ligate the upper part over here. Okay. So how you repair now? I'll be concentrating on to repair the angle. So after you have secured the vessels, the angle can be managed by the normal. We use here a green army touch. I think majority of the center use green army touch in Caesarean section. Okay, so by exteriorizing using green army touch, you can actually see the angle clearly. Okay. Again, when you are suturing as the extended lateral tear, you need to make sure that you avoid the ureter. Okay. Okay. So the next injury that also commonly occurred actually is the extension to lower part. Okay, inferiorly towards the bladder. Okay. All right. So for lateral, for downward tear, okay. So the most important is to same principle. If you see the vessels, so if you see the vessels bleeding, so the vessels need to be searched and ligated. Okay. So for inferior or downward tear, you must carefully retract the bladder. Okay. You can use the doyen. Sometimes, if two lateral and two downward, you can use another retractor such as diverse. Okay, so that it properly retracted over this area to see the downward tear. Okay, so a few technique. Okay, few technique to you may actually further dissect and separate the bladder downwards in this situation. Okay, so let's say if you are unable to. Okay, so first you clamp. Okay, the vessels, if you're able to do so. Okay, if let's say you can see the angle, so the suture you need to start at just to cover the angle over this area. Okay, another technique, especially if you are unable to search for the angle. Okay, you dissect the bladder, you still unable to see the angle. So sometimes if you use the green army touch to retract, you know, the lower segment is very thin, it may torn. Okay, so what we can do actually is just to put a suture as a some sort of stay suture, so that okay, then you tie it. And you cut it a little bit longer. A little bit longer. Okay, and then you can use that as a stay or a pull suture. So you pull and you can see the remaining angle. Then you can suture again to cover the angle. So that's one of the technique. Another thing is I think to cover is the systematic devascularization, especially if you have a bleeding. You already covered the vessel. I mean the tear. The bleeding is not from the tear. It's just, for example, in placenta previa, in raw air, and in placental bed, or bleeding from uterine atony. Before you proceed with measures, more advanced measures, as described in the lecture, you can do systematic devascularization. So the area is the uterine artery. After you exteriorize, then you already have secured isolate the ureter, so you can tie over the uterine artery. So I think I just will show you one, and the other area will show just the area. Okay, the bladder had been pulled down, the ureter had been separated, so you just suture into the myometrium. I think this suture is not, for this model, this suture is not that deep enough, but okay, but you need to cover the myometrium. Yeah. Okay, I will show you on the more clear plane. Okay, you suture until the myometrium. It's not that good. Okay, never mind. I think I will show you the area. Okay, but the suture is okay. So I can show you on the on another model. So the area is to cover the uterine artery. Okay, after you have exteriorized, isolate the ureter, pull down the bladder, so you can take uterine artery over this area. Okay, and another area is you need to cover the anastomosis between the uterine artery and the ovarian artery. Is around the junction of the cornu, okay, just below the fallopian tube. Okay, so you can take a suture over there or onto the myometrium to cover the area of anastomosis. So the bleeding or the blood supply from the ovarian artery could be reduced before you proceed to another devascularization, which is the internal iliac artery. Which, I think I will not show it here. I think that's from me about the management of lateral tear, downward tear.
So sometimes when the bleeder or the tear is on the right side of the uterus, you might want to consider changing your position to be on the left side of the patient. In that sense, for you as a surgeon, the access is a little bit easier to suture because your normal angle is this way, instead of struggling on the same side of the patient and the access is poor. So you do the same thing like this, turn the uterus a little bit, and then you find that you can do your suturing that way. So they're just some of the simple tips that you want to consider. Or if you've got a good assistant, he can do that for you as well.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih.
I think that's about it for this session. So we will have a short recap with Dr. Guna before we proceed to the next demo session. Thank you. The whole thing kan, tak guna kan? Yes. Boleh angkat ke the whole table?
Excuse me, Dr. Guna. Maybe you still mute your microphone because we couldn't hear your voice.
Apologize.
Yes.
You had
Yeah,
seen
it's perfect.
2 demos. The first is on access, about incisions on the abdomen, incisions on the uterus. And the second, you've seen about how to handle lateral tears, tears extending to the bladder. What we showed you are some principles. I hope the video was reasonably clear enough, but you can go back and watch the recording if you want to. One of the questions that was asked by the participants was, will be covered in the next lecture as well, like complication of second stage. Something about adhesions. So adhesions are, as you know, it's a common problem we always face. Now that the cesarean section rate is higher, so you're handling previous cesareans. You do the same principle as what we told you in the beginning. You plan. So if you think that the adhesions are going to be dense from the previous report, you might even want to consider completely changing your midline incision. And some of us have done that. So if the previous cesarean had mentioned that there were bladder injuries, bladder tear, you know you're going to face something, I would do a midline abdominal incision rather than incur another bladder tear. That's being a little bit extreme, but at least you're thinking before you go in, these are options for me. But let's say you do a repeat transverse or dual column incision, you have to tread extremely carefully, layer by layer, because the thing that you're going to face commonly, not so much the bowel, but the bladder. And this is where if you got a good, if you catheterize and you got a bladder balloon blown up, that will guide you how you go. And I tend to go, once after the transverse incision, to go as superiorly as possible to open up my peritoneum, and then I try to dig in to my bladder. You also may want to cut into the rectus muscles, divide them bilaterally to get enough access. And quite often, if the adhesions are covering the entire lower segment, you will then do like a DLIS or a classical vertical incision on the uterus. Again, as part of planning, if you know that the adhesions are anticipated, you'll get someone senior to be with you. You probably want to get the urologist with you as well. Now, there are often cases where we think we've done everything, especially in bladder, and then we close the uterus up, only to find that a week or two later, she develops a bladder injury, she's leaking, and she got a fistula. And we do see that on and off, yeah. So when in doubt, take your time, do a very simple methylene blue test, because the catheter is already there, to make sure that you've secured there's no bladder injury before you close the uterus for adhesions. The thin lower segment, we do come across, especially like you're doing a second cesarean or third cesarean. In a way, it's simpler because it's less vascular as well. Okay, and you don't have to routinely do two-layer closure for very thin lower segment. But the more you do, the more you're going to tear actually. So if you do a one-layer closure, reasonably wide enough, and there's no, and your hemostasis is secured, it's more than adequate. So you don't have to do two-layer closure all the time, especially if it's thin. Obese patients are particularly challenging. Challenging for you, challenging for the anesthetist as well. That part is difficult to answer you whether you want to consider general anesthetic or epidural for such patients. But if you assess carefully and you've done that, then what you need is to be I personally prefer general anesthesia because I want somebody who's very, very relaxed. The special retractors for obese patients, you need a very good assistant with you to get into the uterus. And in obese patients, particularly the lower segment is very difficult to find. So again, you may want to go a higher transverse, or you go into a classical cesarean for an obese patient. If you closed up, of course, you now got the other complications coming in, your VT prophylaxis, for example. There's a question about what to do if you tear the round ligament. The round ligament, fortunately, is not so vascular. So we don't have that issue of trying to control bleeding or hemostasis. But you have to repair. And the usual, if you do an end-to-end closure with a simple sutures, that's sufficient. And you hope that in time, it heals and strengthens. But as you know, it may not. So this ligament may be a bit more prone to, you try and descend later on. You must explain, you must tell the patient this what's happened and watch out for it in the postnatal period. And maybe you can offer physiotherapy, but you have to repair end to end. There's a question about compression sutures, BLH for placenta previous. BLH is primarily for uterine atony. That's a principle. That's how it was designed and that's how it works. When it's so atonic that your medical therapy doesn't work, you then want to compress it. That's where the BLH will work. It does not work for placental previa or bleeding placental previa. But that's a different area altogether. So it's purely only for atony. There was a question on second stage, and we're going to tackle that in the next demo. I'm seeing if there are any other questions that I can see. Switching a low segment, one layer or multi-layer. So multi-layer, which is 2 layers, is recommended. There are enough studies to suggest only 1 layer, and they've followed the patients to have good outcome as well. Wide layer, and they are more careful about hemostasis. They don't want to close in 2 layers. So there's some group of studies suggesting 1 layer is sufficient. I traditionally have done 2 layers for most of my cesareans. If you go by what so the Royal College does, it is still 2 layers. Is the exploration of the uterus done digitally, routinely? I guess you are trying to ask about removal of placenta. Then yes, it is done routinely. After you deliver the placenta by, don't do it manually. It's not recommended. You must do by control cord traction for the placenta. You will then sweep the inner lining of the uterus either manually or using a gauze or a gauze mounted on an instrument like a swab stick to make sure it's clean. You need instrument to take the needle. Do you understand the question? Was endometrium sutured? Endometrium will be invariably sutured in most cesarean sessions. It's very difficult to avoid, but you're just trying to take a bite, trying to avoid endometrium. But where hemostasis is important, you have to include endometrium. So it's not a problem if you include endometrium. Right, I think we are ready to go on to the third demo now. So over to the simulation studio. Dr. Sweet.
Okay, hi. Welcome back. So this session, this demo session is about management of another set of skills or another scenario, which is the abnormal lie and presentation. So I will try to show you as a few scenarios. First, I will show you the management of breach. It is not so complicated. This is not so difficult, but in majority of cases of abnormal lie, you will be ended up delivered by breach extraction. So management of breach or deliver by breach in Caesarean section is very important to master of. Okay, so first of all, in I repeat again. Can I repeat again? Okay, so welcome back. Sorry for the technical glitch. In this session, I will show you or demonstrate to you the management of abnormal lie. So in abnormal lie is another set of skills to encounter under the complicated Caesarean section. So first of all, I will show you the technique to deliver breach in Caesarean section. It is not so complicated for breach per se, but in majority of abnormal lie situations, you will need to end up deliver the baby in breech extraction. So I think all of us, all midwives, obstetricians and doctors in obstetric or managing delivery should master the delivery of breech vaginally, as well as in Caesarean section, because the technique maneuver is almost the same. So in breech, of course, in breech situation, in breech, longitudinal lie breech, there are many techniques. Okay, a simple technique or in simple breech, you may ended up deliver by scooping the buttock, like push from here. You need to okay, like you are managing a cephalic, in cephalic, so it will deliver buttock. I will show you. That's another thing. Okay, but if the head, the head, the foot is a flex, I think it's easier for you to grab the foot, okay, and then carefully by this time you try not to contract it and bring out the buttock. Okay, to push. Okay. Okay, you can deliver another feet. So gently, not to hold the baby on the femur. Okay, so you may you want to avoid the fracture, so you hold at the pelvis. So you carefully, like delivering breech in vaginal delivery. Okay, you do a lot of that maneuver to deliver the arm, another side gently, and in the head, like you managing the breech in vaginal delivery, make sure the head, the upper hand is flexing the head, and the lower part is on the fetus cheek, okay, to maintain the flexion. So that is the management of breech. Okay, so now this from inside. Okay, so now is I will show you the abnormal lie to how to deliver the abnormal lie. Okay, So I will start with the relatively easier one. So a few technique or tips in management of abnormal lie. First of all, the surgeon should anticipate, preferably the surgeon, him or herself, assess abnormally where's the back, where's the head and buttock, and doing scan is a privilege. If you have ultrasound, you do scans before the delivery so that you confirm the lie, where's the head, where's the back. Okay. So I will start with the another tips is actually, as much as possible, you try not to rupture the membrane before delivering. Meaning that while you are entering the uterus, the membrane is still intact, the liquor is there. It's relatively easier for you to maneuver, to search for the feet or to do the flexion, the version. Okay, so I will start with a relatively easier one, which is the transverse lie with the back facing up. Okay, so the limbs facing down or facing to the pelvis. In this situation, if the membrane is still intact, it's a very complacent, privileged situation in which you can just enter your dominant hand to search for the legs or foot. Okay, so I mean that's the technique. You want to differentiate where's the hand and where's the foot. That's you need to practice. You need to feel for the heel. Okay, so in this situation, you search, you enter the incision, you search for the heel, and only if you have already bring the leg out, then for me, I mean my style, then I will rupture the membrane so that I will make sure that the baby will be delivered in bridge extraction before impacted, for example. Okay, in this situation, okay, I will search for the leg. Okay, and it's a bit sticky. Okay, so I will search for the leg. Just there. Okay, the leg is out. Okay, and I will continue to deliver by bridge, like I showed you before. Okay, so I make sure the leg is out. Okay, and the rest will follow. Only then actually I will rupture the membrane so that I can deliver. Okay. So another situation is a relatively difficult situation is where is the transverse lie and where's the back is actually on the, facing towards the pelvis. To make it more difficult, the membrane had ruptured, the patient already in labor, and it's difficult for you to version or to move the baby. So multiple techniques depending on the situation. First situation, the membrane is still intact, the liquor volume is very good. So technique is before you do the uterine incision, you can actually rotate the baby. So you identify actually by your palpation before and by scan, if you have did the scan, where is the fetal back. So you just need to push to follow, okay, and just to push the head back. There's plenty of room. Okay, you can try version, meaning that on top of the uterus, you can do the, like you do a external cephalic version for bridge, for example, you just push the back to the head to the fundus, so that at the end the lower limbs will be on the pelvis, on the lower part, so you can grab the feet like I showed you before, rupture the membrane and delivered by bridge extraction. If you have difficulty or another situation, especially the membrane had ruptured, liquor had been drained, so the baby is impacted with the back to the pelvis. Multiple methods. One of it, you can actually extend the incision. We show you before, you can do inverted T, for example. You can do the J incision. Usually, it is recommended, or my style, actually, I've been taught, I will see where is the leg, either left side or right side, and I choose the double or the J incision initially to the side of the lower limb. So that, let's say it is like this, so I will to the right, so I will extend the J incision at the right side, so it's easier for me to take the feet. Okay, if it is on this side, for example, the fetal limbs or lower limbs on the left side, I will extend the J incision on the left side so that I can enter my hand. To take the food and delivered by bridge extraction. Okay. Of course, another method, like I mentioned before, if you extend the incision, inverted T, and you can deliver. Alternatively, if you have anticipated from the beginning, actually before you do the transverse incision, actually you can perform classical, for example. Okay, if you are already anticipated that is difficult for you to deliver the from the lower transverse incision. So everything actually is based on judgment during the cesarean section. That's why in complicated cases it is considered high risk, and it should be done by an senior and experienced obstetrician. So another method is the the oblique life. Usually it's oblique, either oblique or transverse, in which the hand is prolapsed outside. So I think relatively difficult to show you on this mannequin, but let's say if you have this hand is already out on the vagina, so either you from inside, actually you can push the head to the fundus. All right, most of the time actually the hand will follow, and again you take the leg, you deliver it by bridge extraction. So you never mingle with the hand and try to deliver deliver by hand. I think it's not the appropriate way to manage. Okay, so next one, I think we will try to show you the management of deeply engaged head. Okay, so we try to show you on this mannequin. It's usually common in second stage caesar. For example, you have failed the instrumental deliveries. The os, the station is 0, for example. Head is not palpable per abdomen, so it's a very deeply engaged head. Especially, this is a very high risk because the patient already have gone into second stage for quite some times. The lower part is edematous, very thinned out, and susceptible to injury. So there are multiple tips to try to manage deeply engaged head. One of it, you need to have a very experienced assistant that need to push the fetal head from below. So in our setting in Malaysia, usually a very experienced midwife or a very experienced medical officer in ONG, not the younger one, house officers, a younger midwife that not very experienced in management of this situation. So the maneuver is to push the fetal head by cupping of the fingers. Okay, the reason being is you want to make sure that the pressure is equally distributed. Okay, it's not pointed to one direction, that may increase the risk of injury to the fetal head. So you cup and you try to you need to, if the midwife are unable to identify left and right, but you can direct them, you can direct her, the midwife or the assistant from below, try to flex the fetal head while pushing up to the abdominal cavity. Okay, so we will try on this mannequin, and you as a surgeon, okay, what you will do is actually
Okay, you cut. Usually, I mean, in deeply impacted head, if you cut the incision, we prefer to cut a little bit higher. Reason being because in second stage cesarean section, the cervix had been retracted up. If you incise a little bit lower, you might enter actually into the vagina, in which is very difficult to repair, and you will extend anyway. So slightly higher in second stage Caesar because the cervix had been retracted up actually. Okay, so usually when you cut, you see the shoulder, and then you know that actually it's very down there. So you ask the assistant. It is good actually in this situation to do a cesarean section in lithotomy position. Okay, but okay, so the assistant will push, and you as a surgeon, you can use your non-dominant hand, okay, to enter and scoop the head after the assistant had pushed up. The reason to use the non-dominant hand is less likely for you to flex. So if you do with your dominant hand, majority of the time you will flex down, and it will increase the risk of tearing into lower part and into the bladder, vagina. So the repair will be very difficult. Okay, so after you scoop up, and then you can replace by your dominant hand, and you deliver like a usual cephalic. Another technique actually is, okay, you using your hand, okay, you push in non-dominant hand, and with the help of your dominant hand or the help of the assistant, if you are tiring, you can push the shoulder upward, okay, and you scoop after that with your dominant hand. You scoop the head like usual. Another technique is actually, okay, is to deliver by pulling technique, in which you deliver the by bridge extraction. Okay, in this situation, you insert your hand up, search for the leg, knee, and then the heel. So you retract. The principle is, okay, when you pull the leg, so the baby actually will pull up, and it will disengage the head. And majority of the time, either you do that, you can continue with cephalic, but actually it's easier for you to continue it with bridge extraction. So if you want to do that, it is wise also actually to extend the incision. Either you do the inverted T or J incision, so that it's easier for you to take the feet. Like when you are doing just now for transverse lie with back down. So of course, after the delivery of this difficult situation, abnormal lie, especially that you need to push from below, you need to carefully inspect the uterus after the delivery for any tear, and it is wise also to exteriorize to make sure that all tear and angles can be seen and can be repaired. So I think that's about it. The management of abnormal lie, and we will be happy to answer questions, to share with you, and to show you again any technique. So thank you.
Dr. Sweep, hello?
Yes.
Sorry, can you demonstrate to us once more how we deliver compound presentation with the hand is already outside the vagina?
Okay, so I think Dr. Guna can help. So there are many techniques. Most important is for you to try to reduce the risk of injury to the fetal hand. I mean to the fetal limbs. Okay, so let's say in this situation, okay, the hand is already out. It is an oblique with a head below. So,
for the purpose of the demo, we're just choosing a simplified situation where there's a hand prolapse with this baby's right hand coming out to the vagina. Okay, I can't show you on this model. The wrong thing to do is to go for the hand or go for this hand, right? So all you do, you just glide your hand inside, right? You glide your hand inside. We're now going for this part. And you just move your way across right to the baby's head. Once you do that, inside, this is how it is. You then just keep pushing the baby upwards towards the fundus. And as you do that, the other hand should follow along and come out of the vagina. I made it simple, but if you follow the principle, you usually will get it right. Don't forget, you also need enough of access. So they need to extend the incision on the abdomen or the uterus for you to be able to do that. And by that time, the uterus is already reduced in amniotic fluid. So you're actually struggling a little bit, right? If you have a situation like this, where the baby's left hand is underneath, you want to consider doing the removal by being on the other side. You can come across to the other side of the lady, to the left side of the baby's, of the mother. Same thing, use your left hand to go in, and you're now looking for the baby's back. So go for the back, go towards the head, and then you just push all the way up, and the hand should follow for a compound presentation. So I hope that clarifies a bit.
Yes.
Vidya.
Okay. Thank you.
You tell me, Vidya. So we've tried to cover some complicated situations like, you know, your, I don't know, the abnormalized, the transverse being the back to the bottom, back to the up. We also try to cover your second stage cesarean. This is not easy because by the time you're doing it, as I mentioned, there's not enough amniotic fluid, the uterus is contracting, so you need a lot of manipulation. But if you do it in steps slowly, you probably will minimize all your injuries and tears. Okay, good. We're now ready for the next part, which is your quiz. Give us.
Thank you, Dr. Guna, for the recap and clarification. So we will now going for not really a quiz, but just some will be a feedback for us and partly for you all, and we will see from here what we can do and what we can discuss regarding the next course, for example. Okay, so again, it's the same. Go to Menti. Kindly go to www.menti.com and use this. Okay, so go to menti.com, www.menti.com, and enter the code 6561379, or you can use the QR code from the screen at the screen. Maybe we'll give time about 1 minute for the participants to enter. Okay, those who have entered can start to answer the first questions. How do you feel now? Excited. So I'm not sure whether excited to manage or to hope for a complicated case, or excited to practice and a new technique. So I hope it's not excited to ask for an unexpected complicated case. I think all of us are hoping not to get an unexpected complicated case, hopefully. More confident, good. I mean, at least you know, you get something from the course, new insights. You understand more. Okay, it's good. Anything else? We'll wait for another few seconds. Or need more study. Okay, very good. All of us actually. In this COVID situation, we had not been having the face-to-face training. I myself actually feel more like you know, not to say lost, but by attending this, you know, I get to study and be by myself actually. So all of us need to more study and practice attending courses. Okay. Okay, so I think that's an open question. So I think we might not receive from everybody, but we do hope that actually you gain something, and yeah, it is not to master just attending one course and you are a master to do all that. That's not about it. You need to practice. At least this is an eye opener, and please. You can go to our channel and subscribe our books. Okay, so I think we move on to the next question. Okay, so have we achieved the objective, the learning objective for the session or for the course today? So okay, thank you to all of you also by attending and concentrating. But we do hope to hear from you actually feedback for us to improve in next session. Okay, so we move on. Okay, so this is, I think, the same questions before, just as a reflection. We want to hear from you, especially those who didn't answer the first or the pre-session survey. Will you regularly exteriorize the uterus while closing the uterus during cesarean section? The pre-test is what you have been doing. So now is, will you after this regularly exteriorize the uterus? Majority will majority answer occasionally. So yeah, I think what we want to emphasize is it is not indicated, not necessary in all situations. Only in certain situations, such as a complicated case, extended tears, vessels bleeding, etc. Okay. Okay, we're still waiting for. Okay, so majority will not regularly exteriorized, especially in a simple case, a normal cesarean section. Okay, so are you convinced or confident enough to perform resuscitative hysterotomy now? So we just had in our hospital, in my hospital we have been practicing now, we just had one last night. We just heard from the on-call team. They just had have one resuscitative hysterotomy in the emergency department, red zone of emergency department last night. So yeah, occasionally, actually, especially in big hospital, you will encounter perimortem cesarean section, or now we call it resuscitative hysterotomy. In fact, resuscitative hysterotomy had been included in the syllabus of emergency physician rather than obstetric and gynecology. So in some centers, in some countries, resuscitative hysterotomy is included under emergency procedures that need to be not to say well versed, but need to be at least known and by the emergency physician rather than just by obstetricians. Okay, so half 46%, about almost 50% said that you are confident to perform resuscitative hysterotomy. That's good. We hope that in the future we will see more blue color in these questions. Okay, so few skills you can drag the according to the level of confidence, from less confidence to the right, very confident in each of the skills now. So are you confident? How confident you are in performing cesarean section in second stage? Prepare the extended tears, manage or doing a cesarean section for malpresentation, malposition, and abnormal lie, and placenta previa, and doing compressive sutures for uterine atony. Okay, so it's interesting to know. Okay, so the I think the confidence level slightly increased from the morning's questions. We see also the least confidence among the participants is the compressive suture skills. It is interesting because actually we have not gone into a very detail on compressive sutures in this session or in this course today, but we have it actually as a separate breakout session for compressive sutures in our full ICOE session for 2 days course. So we do hope that actually maybe we can go about it. Okay, so in the next course maybe, inshallah. So okay. Okay, so as a feedback for us, we do appreciate your rating or your comment by rating this the whole course. How's the program overall, trainers, how the simulation sessions, and also the simulations, mannequins, the lectures, demos, and audiovisual quality. Okay, any answers coming? Okay, I think it is quite standard in all our courses. Participants love the simulation, the demos, the hands-on, the breakout more than the lectures. So yeah, over the years, we have tried to reduce the lecture and increase actually in the simulation, the demos part of the course. So thank you for the rating. So we do hope that we can improve the course in the future. Okay, so I think last two questions, or maybe this is the last. Will you recommend this course to your colleagues if we are conducting another course? Okay, so majority will recommend. Maybe those who who would not recommend the course to the colleagues can share with us the reason, so that we can improve anything to improve, or the title or the content, so that next time we can recommend the course. Thank you for the. Yeah, so sorry. Okay, can kindly give some suggestions so that we can perform better, collaborate, and conduct a better course. So just give a suggestion how we can go about it. We appreciate your suggestion, your comments. Okay, we could practice more group session with the break room. So I think simulation is very important. That's the target of our course actually, because in obstetric emergencies, there is no way we can practice properly in the real situation, because if it is happening, the real situation would be, very tiring, exhausting, everybody in panic. So it is not time to practice during an obstetric emergency. So that's why the simulation is very important. So group session with break room. So I think if you can bring the whole course like we did in KL and few countries over there, it's very good. We can practice on the mannequin. We have a group session with break room. I think we can go about it after this. Okay, so beside from this survey, you can write to us or email. You can leave a comment on our channel for our feedback. Okay, longer discussion. I think we will have one more session after this with all of us. Okay, so I think that's the end of the survey using Mentimeter. Thank you to all the participants, and we'll move on to the next agenda. Thank you.
Okay, thank you for Dr. Ahmad Swib, also Dr. Nur Zarina, and also Dr. Gunar for the nice presentation, nice demonstration for us. And now we will have feedback from the audience. I think that some of the questions has already answered by Dr. Gunnar. Maybe is there any questions more from the audience? I think this is an great opportunity for us, for the residents, to ask from the experts here. Okay, before we waiting for the questions from the resident, I think there is still questions from the chat box. Dr. Okta, our senior doctor, asks, which is one better when we open the lower uterine segment? Is it the sub technique or the blunt technique craniocaudal? That's the question.
If you follow some of the guidelines that we use, the blunt technique is less traumatic. And I'm guessing by what you mean by the blunt technique is when you enter the lower segment, you're just going to. That's a blunt technique.
Yeah,
so
wider bluntly.
that's less traumatic.
Yes.
But at the same time, I think all residents should be trained in both the blunt and the sharp, because sometimes when the uterus is a little bit extroverted, if you're not careful when you use the blunt technique, you might go more to one side than the other, you know. And the tear, especially if she's been in labor for a long time, lower segment is a bit softer, it can go downwards as well towards the bladder. So if you use a sharp technique where you can guide the tear like a little smile in the lower segment, then if you extend, it's going to go that way, upwards rather than downwards.
Okay.
So yes, you select the type of lower segment you're dealing with and then use it appropriately. In general, for an elective Caesar, probably blunt technique.
Okay. So in Malaysia, you usually done a blunt technique for the to lengthen the lower segment.
Yeah, correct.
Okay. Okay. The next question is from our residents, Dr. Yosinov. He asks whether if the patient has history of C-section 2 times, is there any chance for those patients to deliver vaginally in their future pregnancies? That's the first question. And the second question is, to prevent risk of adhesion in the future re-C-section, is there any technique we can use when we perform primary C-section? That's the question from our
second question.
Pardon?
What's the second question?
The second question, is there any technique for the primary section to prevent from adhesion in the next C-section?
So for the first question, I think the simple answer is no. So 2 previous cesarean, the risks are high. You would not want to consider normal vaginal delivery. You'd only consider under very special circumstances, i.e. you know the history of the 2 sections very clearly. The third delivery is conducted by someone senior. And for third one, the patient herself signs a consent that that's what she wants.
Okay.
And fourth, if you do go for normal, you would give a very limited try.
Okay.
Perhaps say 8 hours without augmentation. So those are special circumstances. But in general, I would say if you are dealing with a hospital setting where we don't know much of the history sometimes, probably better to go for elective C-section. Reducing adhesions or subsequent surgeries is the same principle as any surgery. You know? So less instrumentation, less manipulation, and you make sure that you achieve your hemostasis. Sometimes you may want to, if you don't want to clean, you want to mop up the remainder blood or clots very carefully, and that should be sufficient. While in gynecology, we use a lot of anti-adhesives, it is not mainstay for obstetric patients. So I don't use that. Besides that, I don't think you can do much more.
Okay.
Zarina or should we want to add something to reduce adhesions?
I think the technique is very important. Less instrumentation, less manipulation, like you mentioned. The use of certain anti-adhesive, I think, is not really recommended. But another thing is, for me, is the most difficult or most common problem to encounter regarding adhesion is actually the bladder, which is very high, so the risk of injury. So I think by nowadays, good practice, they are not recommending what you call that, the separation of the bladder downwards, just limited opening of the UV fold as in the area that we want to cut. And I think by leaving the UV fold open, I mean, the studies is not strong, but by suturing, sometimes, you know, if you suture quite high, by closing the UV folds quite high, also I think can be a factor to adhesion in the next season section. Of course, to reduce one thing, but we are handling the previous season section, I mean the previous scar. So while we are doing, I think, careful dissection, I usually will not hesitate to cut the rectus muscles if you need to do so, especially in previous scar, if you cannot find plane at the center, especially. So, and then another thing is, I think I will go as high as possible, meaning opening the peritoneum as high as possible, searching for the plane, and then I mean cut lateral, and then we go to the middle, because that's the area that usually the bladder will go up at the middle.
Okay.
Yeah.
So it could help prevent the injury to the bladder as well.
I think that's more important. I mean, because we don't. I mean, we are dealing with the season now, so everyone. I mean, addition had occurred, so that's most important actually.
Okay.
To deal with the addition.
Okay, thank you. Oh, sorry, I have this question is from our senior consultant here. Dr. Dia asks regarding Billings compression suture. It is said here that Billings compression suture is compressing the upper part from low segment of the uterus. Meanwhile, bleeding from placenta previa is from the lower part of the low segment of the uterus. Is it useful to manage bleeding from placental bed from placenta previa, the Billings suture?
Yes, you can use compression sutures on the lower segment.
Oh, okay.
Especially for bleeding vascular bed from previous. So it's like, so while the compression suture normally is from the top to bottom, but like a village, here you're going this way, for the lower segment. You're trying to close up the thing. I'm not sure whether it's called Heyman, so there might be another name for that.
Heyman
that you're trying to compress in vascular bleed. In placenta previa, as you know, you are using all techniques possible that you have to try to, it's the tools that you have to try to minimize the bleeding. So besides, making sure you use a lot of compression, some of us use some antihemolytic agents to freeze the vessels. You can use your balloon tamponade to do a compression, and of course you can also do a compression externally. So all techniques can be used.
Okay, thank you, Dr. Kunar. I think that due to the time, I think we can, on the behalf of our department, Obstetric and Gynecology Department, Universitas Gadjah Mada, I would like to thank thank you very much for your effort, for this webinar, and also for the demonstration for us. I think it's very important for us and also very useful for us. Thank you.
It's been a good experience for us,
Mhm.
definitely. And I'd like to thank both my trainers who've been patiently practicing from yesterday and rehearsing and teaching today. Thanks to them and to my staff at the OGSM, Bhaskar in particular. I would encourage all the participants to go to the website. We will share with you later in the slide. It's got lots and lots of information, lots of teaching videos that we've done on various aspects of emergencies, including compression sutures and parts of cesarean. So they will benefit a lot. And do look out for future meetings. The next program that we have, which I think will be very useful for most of the trainees, is on episiotomy.
Oh, episiotomy.
Common, simple technique, but sometimes not taught properly. So this is aimed at junior doctors, residents, and maybe even midwives. It's a modular course. You can sign up from where you are because everything's on a teaching video. So you go to the website, you pay a small sum to register, lots of videos for you to watch on complications, techniques, what to avoid, etc. And then there is another hands-on about 2 months from now for those available. And you'll be given a certificate for that. So it's something that you can do at your time from where you are, and you get a certificate. So that's the immediate program that's coming up. I'll share with you. But there are also lots of other courses going on.
Okay, again, thank you very much for Dr. Guna, Dr. Nur Zairina, and also Dr. Ahmad Sweb. I think before we close this webinar, I think Dr. Natina, should we take a photograph together?
Yes, doctor. We can take a picture with all of the participants to memorize today's seminar. All right, so maybe all of the participants, can you open the camera and smile to the camera so you can take a picture together?
Must be 106 faces.
So everyone's ready? All right, yeah, so I can see there are some of participants who haven't opened the camera. Okay, let me inform you once again, can all the participants open the camera and smile to the camera so we can take a picture together? All right, maybe we can take some of the pictures first. Okay, look at the camera and smile. All right, 3, 2, 1. Okay, maybe once more. All right, smile to the camera. Maybe you can do the peace sign or whatever signs that you want to show. All right, 3, 2, 1. Okay, looking pretty good. Maybe another participants. Okay, smile. 3, 2, 1. All right. Yeah. I can see all of the participants looking so happy and enjoy these lectures, Dr. Sinta. Because this lecture is so interesting and also is delivered by such amazing speakers to Dr. Guna, Dr. Nur Zairina, and also Dr. Ahmad Swib, who have delivered such interesting and clear explanation.
Natina, excuse me, Dr. Natina, we should also thank to Mr. Bhaskaran for the technical.
Sure.
Yeah.
Amazing.
Yeah, sure. Yeah, also thank you to Dr. Mr. Bhaskaran as the IT team from ICO. Okay. We finally came to the end of the lectures. So let us close the seminar by reciting Hamdalah. Bismillah. Alhamdulillahirabbil alamin. All right, so those are the agenda, the lectures, and also the demo that we have presented to you this morning. So we hope you learned something from today, and thank you so much to the ICO team and also all of the speakers and also the team for Department of Obstetrics and Gynecology Universitas Gadjah Mada. I hope in the future we have more collaboration between the ICO and also Obstetrics and Gynecology Department of Universitas Gadjah Mada. So see you in the next occasion. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Have a good day,
Bye.
everyone.
Thank you. Thank you very much. Bye. Okay. Bye bye. See you later.